Ủa nãy giờ anh Nam đâu có nói gì đâu phải Minh Nam?
Hi, Andrew.
Good morning,
Uh,
or good evening, I guess, for you.
it's evening in Vietnam time.
Yeah,
Yeah. How are you doing?
I'm doing well. You're
Yeah.
doing okay?
Yeah. Everything is good. We moved to a new center, so a lot of works, a little bit busy.
Gotcha. Where is your new center?
Yeah. New center is next to my old center. We just built a new building, and
Oh,
we moved from the old one to the new one. Yeah.
oh, wonderful.
Yeah. And in the new center, we have more room and more facility for development. And in this morning, they have opening ceremony. So our boss will discuss to invest in gen testing and
Oh, great.
a lot of things.
That sounds exciting.
Yeah. So I think in the next few years, this area will be helpful for our hospital development. So we really need an expert opinion and a lot of things we need for the new building. And gen testing is one of the subspecialty that my hospital want to develop in the next few years. Yeah. And I see Hoàng. I also invite Hoàng to choice. Hello. Maybe I wait a couple of minutes. I will make a test to Hoàng to invite him to choice. Yeah. Hello, Hoàng. In this discussion, I also invite some of my colleagues around Ho Chi Minh City to choice, not only my fellow or my colleagues in Children's Hospital 1. I also invite some doctor from Children's Hospital 2 and the new Children's Hospital. In Ho Chi Minh City, we have three children's hospital. So when you come to Ho Chi Minh City, I will take you go around to see not only my center, also Children's Hospital 2 and the new city Children's Hospital. So you can make an overview of the number of cases in south of Vietnam. Yeah,
that'd be great.
Yeah. So today I want to introduce you to Dr. Hải. Dr. Hải is my boss in cardiology department. So she will help us with the program. When you come to my center, I will introduce you to Dr. Minh Hải and Dr. Hào. Is a direct boss, so they can support you for all of the training and all of the research about gen testing. So today I want to introduce Dr. Andrew. He is very famous, well known around the world. When I read about the guideline of AHA about the gen testing in congenital heart disease in children, I see his name is in the first of the board of guideline committee. So I'm very happy and very proud that Children's Hospital 1 can invite you to share your knowledge. Of course, we just put the first step in the gen testing. So some case I present today maybe is not full data for you. So, but I try to the next presentation I will try to make everything will be better. And I hope that when you come to my center, you will have us to improve our knowledge. So I want to start with the case presentation first. We have 4 cases. So I want to share the first case. Okay. This case is a male patient, is 19 months old, with the clinical status of poor rowing of both body weight and height, slow mental development, and right now the baby is still just can say, can communicate with a single word speaking, and during examination shows start status with increased heart circumference and low earlobe attachment and cryptorchidism, and family history that both the parent both have short status. Father height is in here, and mother height is the same. So the patient referred to our center because of cardiac problem with hypertrophic cardiomyopathy and pulmonary vein stenosis. And because of the patient have a lot of problem in here, so we do the gene testing, and in first examination, we suspect the patient have Noonan syndrome, and this is the image of this patient. The patient have because of pneumonia, prolonged pneumonia, and this is the gene testing results. We found that two abnormal of the gene in here, PTPN11 and this one. And when we describe this abnormal, we see a lot of description about this mutation. Some they say it's a Noonan syndrome, but also they describe to us it's a Leopard syndrome, and you will see in here we see a lot of syndrome. Also have hypochondroplasia, maybe appropriate for this symptom of this patient. But I also see a lot of syndrome in here. I'm not sure this syndrome is associated with this patient, and the gene results have a lot of explanation. And in the green bar, they also say that this gene is cause the problem. Is the main gene can cause the disease, and the position of the abnormal in chromosome 12 and chromosome 4, I think is very common in our center. And well, we want to discuss about this case because we have abnormal about 2 genes, and but in clinical it looks like the patient have the symptom of Noonan syndrome, but definite diagnosis in this case, we consider a lot of syndrome in this case. And another defect can be explained by this 2 mutation. Is maybe 2 mutation can explain everything for this patient. And what gene will be focused when we decide to test for family member, because you know that the cost of gene testing in Vietnam is very high. So we want to focus on 1 or 2 genes to explain for the family. But the result is make us confused. So yeah, I hope that you can explain a little bit about this.
Sure. Well, this is a very interesting case, and you presented it very, very well. And thank you for the invitation to come and join you to talk about these cases. I think anybody would find these cases that you have here challenging. So it's not just you. I think these are the kinds of things that oftentimes we talk about and we don't know the correct answer. But in this case, a couple of points. So I think I like what you did by making this sort of clinical diagnosis of Noonan syndrome first, right? Based on the pulmonary valve stenosis, the short stature, right? And it's important to not lose sight of the clinical evaluation of the patient. And so for me, hypertrophic cardiomyopathy in the setting of pulmonary valve stenosis is very suggestive of Noonan's or a rhasopathy, but particularly Noonan syndrome, right? So with that in mind, it becomes easier then to interpret the gene testing. So if you go back to your genetic testing results, mutations, of course, in PTPN11 are a major cause of Noonan syndrome. And so there's a very nice match there between the clinical diagnosis of your patient that you've made before you ordered the gene testing, right? And the confirmation of the phenotype based on the gene test. So I tend to think of the gene test as confirming what you're already suspecting clinically. Okay. And in that case, it's pretty clear that this child, I believe, has Noonan syndrome. Now, when the gene testing company gives you the report, they don't know everything that you know about the patient, right? They don't know the family history typically. They only know what you send them. So they have to be very broad in how they convey information to you. So they can't necessarily be very specific. So they list a lot of things that may or may not be appropriate for your patient. So things like leopard syndrome or other types of rhasopathies are on there, as well as potentially lots of other diagnoses, right? And that is the thing to remember with that is those are all possibilities, but they all are not present in your patient, right? Which is why it's so nice that you made a clinical diagnosis first, because then you can go through this and say, oh, the Noonan syndrome variant is probably it. And then you can sort of ignore, right, all the other possibilities on the list. Does that help? Oh, I think you're on mute. Dr. Ann, I think you're on mute.
So the next gene, you think that when we test
Yeah.
for the family member, we just focus on the first gene or
Well,
Yeah.
so this FGFR3,
yeah.
what sort of testing was sent? Was this
The blood sample.
blood sample? And then did it include diseases of the heart as well as other types of diseases?
Yeah, just the heart.
Because of the short stature?
Yeah.
So FGFR3 is not typically associated with heart conditions, but because of the short stature in the family, this variant was found, probably. Although I'm not quite sure what the gene testing was that sent this. But if my Vietnamese is very, very bad, but it looks like they have deemed this a likely pathogenic variant. Is that true?
Yeah.
So both the PTPN11 and the FGFR3 are likely pathogenic, which means there's a 90% chance or greater that these variants may lead to disease. Now, the PTPN11 is easy, right? Because you have made your clinical diagnosis and it matches very well.
Yeah.
FGFR3 is a little bit harder because that clinical phenotype typically can be short stature, right? Those kinds of things.
Yeah.
And both PTPN11 and FGFR3 have short stature as part of it.
Yeah.
Although FGFR3 is probably a little bit different. You know, they tend to have shorter long bones and things like that.
Yeah.
So my sense is that in your patient, they are probably both there. They probably are both, but they're leading to two different diseases in the same patient. Does that make sense? One with short stature, one with Noonan.
Yeah.
So that may be why your patient is smaller than other Noonan syndrome patients.
Yeah.
Right?
Yeah.
And then when you screen the family, this is the importance of what we call cascade testing. So you have one patient with the genetic mutation, you have to try to find other people in the family who have the same mutation, because they may be at risk of having the same disease process, even if they're asymptomatic, or they can pass it down to future children who may have, like your patient, early onset disease, right? So the easiest thing to do here is to figure out what the inheritance pattern of both of these variants are, and they're going to be independent of each other. And because each of these can cause disease in an autosomal dominant way. So each one by themselves can cause disease. It doesn't mean they're going to, but it means they can. So I would probably start by looking for just these two variants in both of the biological parents. Are both parents short stature, or does somebody have a heart condition, or what do you know about the family?
Family just have just only parents have short stature. Other member is normal, look normal, and
okay.
Maybe as we discussed, maybe it's two different.
I think it is. I think it is. The second one is sort of incidental, right? Because we weren't anticipating it. But they're probably both disease associated and probably independent of each other. So they may have both come from mom. They may have both come from dad. They may be one from the other, or the patient may be what's called de novo, the first patient, the first person in the family. And so both parents will be genotype negative for both of these variants.
But as one more question is, this type of genetic abnormality is very common in other countries outside Vietnam, as your experience?
Well, so FGFR3, we don't test for them much because there's no heart condition typically associated with it. But PTPN11, very common. And I would actually say there was a paper last year in that came out that said individuals who look normal, normal stature, everything is normal except for pulmonary valve stenosis that's really thick, right? Doesn't respond well to ballooning, oftentimes requires surgery, that those individuals are PTPN11 positive about 25% of the time, with only an abnormal pulmonary valve. So those variants are very common.
So it's very common. So yes, I hope that all of my colleagues can share this, can understand this. So with this result, I think it's very helpful. So maybe we can go to the next case.
Sure.
Okay. This case, the second case, is 14 months. For the status, the patient have muscle hypotonia, dilate of cerebral ventricle, slow mental development, and the patient come with us because of prolonged pneumonia, and congenital heart disease is very mild, just PDA, and we also close by device. But there also increase in NH3 in blood. Family history is look normal, and we just first with diagnosis we think this is a metabolic disease, and then we do the gene testing to confirm that what happened, and when we do the CNP, and they also found that the lesion of the chromosome 4 and the segment is in here. 4p16.1, and one is a duplication in the chromosome 4, and the segment p16.1 to p15.31. And when we check for the gene, we see what happened in the database, and we see if the loss of this region have a lot of things, we see cataract, deafness, Wolfram syndrome, ocular auricular syndrome, and we see a lot of gene in here, and the syndrome is very depend on the type of the gene in this segment. And once again, in this case, make us more confused because gen is not only a gen, a segment.
Yes.
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 And a segment had a lot of gen, and first with diagnosis, we just think it's a metabolic disease in
Yes.
some crab or something in there, but the result is very different. Very
Yes.
different. Yeah.
Yeah. So this is if you go to the gene test,
Yeah.
these types of changes are very hard sometimes to interpret, especially when you have multiple genes affected, right?
Yeah.
So here, like you were saying, on chromosome 4, a piece has been deleted. That's the deletion. And then the duplication means another part has been copied.
Yeah. Yeah.
Right. And so you're dealing with sort of two genetic problems, right?
Yeah. Yeah.
In the same patient. Now, again, so the important thing here, right, is to go back to the clinical picture of the patient.
Yeah.
The congenital heart disease here of a PDA is oftentimes not genetic, right? There's probably not a strong genetic basis for this. So you're looking at other things that are not cardiac here. And you did the right thing. You looked for sort of these gene copy number variants because we know that when there's lots of organ systems involved, here, muscle tone, brain formation, developmental delay, that copy number variation is the place to look first. So that's important thing number one, right? Is that you got the right test. Now, not every test is easy to interpret. So all of these genes may or may not be involved, right? And many of these genes, the way that they cause disease is not necessarily a deletion or a duplication, but rather a variant in the gene itself. So there are plenty of genes that have mutations, variant changes, missense variants or something like that in the gene that behave very differently when you delete it or when you duplicate it. So I would not go too far into this because it's not going to be helpful. It's not going to be helpful. So my advice here is to try to figure out if this is associated with the disease of the patient. And it very well might be, but it may not. There are a lot of genetic variants like this, which are small deletions or duplications in healthy people. So you almost never know, like, well, what's the cause? And so the best thing to do in this situation is actually to, like with the previous case, to gene test the parents. Because if neither of them have that duplication deletion mutation, this one, if neither of them have it and they're both healthy, they do not have the phenotype of the patient, the disease of the patient, then it's much more likely that this is associated with the disease development in the child, right? Does that make sense?
Yeah.
And indeed, there are a lot of syndromes and things that can come from deletions, duplications in this region of the genome. So it's very likely this is associated, but I would go to the parents. If one of the parents also has the same deletion duplication, and they're healthy, then it makes it a little bit less likely, perhaps, that this is the cause of disease. And then if you do that, say it's the mother that has this mutation, and they have two sisters and their parents, everybody has the same genetic change and nobody else has any of the things the patient does, it's less and less likely it's causative, right?
Okay. So the next step in this case, maybe we explain to family, plan them to check for this duplication. So we'll do the CNV just enough, right? Just CNV.
How do you do your CNV testing?
We take a blood test or take a sample from here, and send to them, and we also write some main description of the family. So we just tell them to check this one for us, and they will focus on the chromosome 4 and chromosome
Yeah. So when you do the next testing, the cascade testing in the parents, you're right. You only do this.
Yeah.
You only do the thing that you're worried about, because the parents may have other things that makes it even harder to interpret, right?
Yeah.
But your question is here. So the main point from this and your previous case is to make your clinical diagnosis first, and then always view the genetics through the patient, right? Start with the history like you did, physical exam, cardiac evaluation, non-cardiac organ system evaluation. And then that's your foundation for everything. The genetics helps a little bit, but it almost never replaces that, right?
Yeah. So very helpful, because when we focus on the gene and in the missing segment, we see a lot of things. And
it gets very confusing,
the
right?
easy way is just come back to the family and
back to the patient.
Happened. It's very excellent idea. Thank you, Andrew. So we just pass in on of this gene. And the third case is the patient, 3 years old, come with us with congenital heart disease, coronary trunkus defects, DLRV with PSD and TGA and PS. And the patient is look like a very, very similar to the Dijors syndrome, and absenteeism, hypocalcemia, abnormal face appearance. So we think this is Dijors syndrome, and complex, very typical. And then we do the fish with the Dijors. You will see in here they send to us. There is normal, 100% of all of the phases are normal. Yes. They also say to us that 200 cell they check, and 100% is look normal. But you know that everything in our clinical status, everything is very, very appropriate with Dijors syndrome. And for this case, we go to the next step, gene testing for CNV, or we check
you're right. No, you're right. Again, here too, right? So important. The patient really fits the picture of Dijors. Everything is Dijors. Everything. So the patient, whether or not the gene test is positive or negative, the patient has Dijors. So then it's easier to interpret the fish. So the fish, we actually don't use fish a whole lot, because the sensitivity of fish cannot see small deletions, right? It requires big deletions. So about 1 out of every 4 Dijors patients, if you conduct fish on them, it will be normal, because because the part that's affected, the DNA is so small that the fish probe doesn't see it, so it reads normal. So if you do CNV testing, is that the gene code G4500? Is that the test?
In Vietnam we call this a test, and it's they check for 4,500 gene, so they call it the G for 4,500.
Okay, I'm going to look it up here. Is this from that Gene Solutions?
From Gene Solution.
Let me make sure this will give you what you're looking for.
Usually they check for all of the possible gene that cause this syndrome. Say that. I'm not sure, but
so this looks like a big test.
A big test.
A big. When you only want the little piece, right? So if you order a big test like this, which looks at all of these genes, you may get what you got in the first patient, or the last patient, right? Something else.
Something else.
So it might be good to talk with them, because what you really, you can do this, it's going to be fine. But if you know you're looking for Dijors, then if you can find something that's a bit more focused on the 2022Q region, you could go for that. Now, I don't know if it's possible through them, but just know that the bigger the gene test, the more likely you are to find something that is weird or funny or confusing. Um, just so that you know.
Yeah. Okay. So in this case,
but this test should give you the answer.
Yeah. So we can explain to the family is okay. We just go ahead with the diagnosis. What we have, diagnosis is still in the paper when the patient is charged.
Yes.
And we just follow up this patient like DiGeorge syndrome. But it's very interesting case. We see some cases like this.
The one thing to consider too is for your DiGeorge patients. If they fit the picture of DiGeorge, you can. Is it cheaper to do the fish than it is to do the G4500 CNV test?
Okay. Fish is usually cheaper, so we suspect we will start with fish,
and then if negative, I agree, go to this test. Perfect.
Okay, and the next case, I think this case, we also in emergency room is a very interesting case. I have also 3 or 4 cases like this, but in the past we don't have gene testing. Right now, this patient is we have gene testing, so very interesting. The patient is 5 years old and have a history of upper sudden death. The patient have syncope when exercising in school, and the patient have a basic life support by teacher and primary healthcare team at school. So the patient referred to the province hospital, and then have the advanced life support. And the patient, luckily, partly recover after resuscitation.
Good job for the school. Great job.
But the teacher is very, very good. There also a primary is not a doctor in school. In Vietnam, each school they have a medical room, small medical room with some teacher in there can be trained to the basic life support and CPR or something very good. And it's very helpful. So this case is very lucky when the patient dropped down.
This is
on the
perfect.
teacher and everything, they do the CPR. Very helpful in this case. And I'm very surprised that they do an excellent job at this case. And
can I ask a question about this case really quickly? Do you have automatic external defibrillators?
No. Right now we it's a very limited payment for all of the device. I know that other countries like around Asia is very common in airport, train, everything. They have a device in there, but in Vietnam it's not common, and even doctor cannot good at using that device. It's that's thing we will improve in the future, and I think it's in its facility like school, train, everything need have a device like this. And
well, I mean, in the US, we don't have them everywhere that we need them too. But the teachers and the school should feel really good about saving her life. I mean, that's a wonderful outcome.
There's a very excellent outcome in this patient. So the patient referred to province hospital, the nearest hospital, and the patient partly recover and monitoring during the patient in the ICU in there. They also see the VT and short VT. So they call me. What we do next, what is diagnosis? And I very wonder because the first, I don't know what happened in this patient. A lot of reason, I think. And I asked, please send me some ECG, some that data so I can explain what happened to family. The patient have normal family history and patient don't have any syncope before. It's the first time patient. And this is the chest X-ray of patient. It looks normal. There is no trauma, no it's accident in here. And it's the ECG from the province hospital. Very, very interesting. The patient is in coma in the intubation, and they monitor the ECG and they send me. This is the ECG. You will see it's look like polymorphic VT.
I would say it's a very specific kind of polymorphic VT. So do you see the 180-degree change in the ventricular ectopy from beat to beat?
Yeah, yeah.
That's bidirectional VT.
Yeah. Bidirectional.
And very specific for this disease. So if you ever see this, it can only be one thing.
Yeah. First of all, I just think about the VT. So as we discussed, and we see again, and I see it's very typical. Yeah, you see in positive, negative, alternative.
Yes.
So everything is look fine. And then at rest, when the patient, when they dip sedation, sometimes the patient wake up, the VT come. And then they're very afraid of that. And I also wonder at that time, I don't know about this disease. So I very wonder. And they also use some epinephrine for resuscitation.
For the resuscitation, yeah.
When they use epinephrine, some kinds like that, the VTN come back. VT come back, and it's very appear very so many episodes in the ICU. But when the patients came down, we put a lot of sedation in there. The ECG become normal like this. Everything look normal. It's very interesting. And then the patient come back when the patient wake up. When they see that patient can win up from intubation, the patient wake up and everything come back. And at this time, you see in here VT come back. And then refer to our center. They sedate the patient again and send to our center again, the patient in the ICU. And then we do the ECG, Hunter, and you will see in here. And that time I think about maybe the disease of CPVT. I read about that. Maybe this is the first case in my life. I see this CPVT.
It's a good case.
Before I read about it, but this case is the case that we have evidence with gene testing.
No, this is great.
And I see a lot of VBC in there, but the version is better. We not epinephrine and other, and then the patient wake up and still see the VBC in there, but everything look stable. The patient still stable.
So can I ask? So here, with the heart rate of 58 and a resting heart rate of 46, was the patient on any medications at this point, or was this just their native heart rate?
At this time, I decided to use a beta blocker.
Okay.
But it's very difficult decision, as you know, that the patient cardiac arrest with everything. Every colleagues in ICU think that it's very severe. We need to support the heart. We need to use
with cardiac.
A lot of things. So when I decide to use the beta blocker, everything very surprised. That's why you use a beta blocker in this case. The patient is very severe, and the patient is just recover. You have to use the medication to support the heart. But I also see when I use the beta blocker, the VBC become just monomorphic VBC and not change the axis of the VBC. And you can see in here.
Okay. So can I just interject here? So that's a very important point. So generally, if there is a cardiac arrest, right? Oftentimes with a sustained amount of resuscitation, there is depressed cardiac function. And so, but it's typically mild to moderate, and it's typically just temporary, right? It's just very brief. So if the differential diagnosis, the things that can cause out of hospital cardiac arrest, are almost always arrhythmias of the heart. Or they were arrhythmias from something else, like a heart muscle condition or myocarditis, right?
Myocarditis.
So typically what we do is when they come in, if the systolic function of the heart is moderate or better, and especially if we see ectopy, let alone VT, if we see PVCs, we will start beta blocker right away, because almost all of these are arrhythmic. So you have to reduce the potential for the arrhythmia to recur. It can be challenging if the heart squeeze is very bad and they require epi, but in these types of situations, beta blockers are really important. And sometimes people will say, well, look, the resting heart rate was 46. right? Do you want
Yeah.
to give them a beta blocker?
Yeah, yeah,
And the
yeah,
answer is yes.
yeah,
So every patient with CPVT
yeah,
is going to be bradycardic.
yeah, yeah,
That's part of the disease, right? Their heart rates are going to be in the 40s.
yeah, yeah.
But bradycardia should never be a reason by itself why you do not start a beta blocker, right?
Yeah, yeah, yeah.
Because the beta blocker here was absolutely the right decision and life-saving. So
Yeah, yeah,
unless the heart is really badly,
yeah,
the systolic function is impacted, we give beta blockers
yeah.
as the frontline therapy for every patient, even especially if they have ectopy.
Yeah. Yeah. So even with we suspect of the CPVT, but very low heart rates, beta blocker is still indication. Yeah.
Yes.
Yeah. Yeah.
Yes.
Yeah.
Yep.
Yeah.
Absolutely.
Okay. Yeah. Yeah. So we do the gene testing. We have and then we found that it's very specific. But as other gene testing results, only we see the result with not only CPVT. They also say that the ARVC, the Alzheimer's right ventricular dysplasia, is very common. It's very. My question is that, of course, in this case I will focus on CPVT, everything appropriate, and we prescription for beta blocker. But when the gene testing send us, usually we have to discuss again.
Yeah.
We do the MRI for this patient.
Yeah, I was going to ask what.
Yes, yeah.
What's the MRI?
Yeah, the MRI is the normal, and
okay.
just some signs of the hypoxia after the cardiac arrest.
Sure.
And Dr. Hai also helped me to do MRI in this case, but not for specific, just a little bit lesion for cardiac arrest after that.
Sure.
But the most of the case after this case, I also see some case, but in other case have the same situation, and they also write the result that ARVC. That you think that this gene is very common for that kinds of disease. Yeah.
Yes. So no. First off, again, so fall back on your clinical diagnosis here.
Yeah.
Cardiac arrest, normal ECG, ectopy, and VT with catecholaminergic stimulation, right?
Yeah.
Epi, or the child was playing at school and running, right?
Yeah.
Suppresses with beta blocker, and then there's that bidirectional component to the VT.
Yeah.
So that is CPVT.
Right?
You know it's CPVT. It's absolutely CPVT.
Yeah.
The gene test confirms it because RYR2 variants are cause CPVT. Now, again, the gene testing company doesn't know everything that you know about the patient. So they're going to list things that some people think are associated with RYR2 variants as well. Yes, arrhythmic cardiomyopathy can be caused by variants in RYR2, but they're very rare. And actually, there is this group called ClinGen, which has a bunch of experts that review gene disease relationships, and they have removed the association between ARVD and RYR2 because they say all of the cases of arrhythmogenic right ventricular dysplasia were actually CPVT, and there's almost no evidence or very little that it is a different disease process. Does that make sense?
Yeah, I know.
So your patient has CPVT. I would sort of ignore number 3 there, right?
Yeah, number 3. Number 3.
Not ignore it. It's fine.
Yeah.
Now, the one thing sometimes you can see with very specific mutations of CPVT is a couple of things. Does your child have a normal endomyocardium? There's no non-compaction of the myocardium.
No.
Right? Okay.
We do echo, everything look normal.
So I would recommend every once in a while, every couple of years, repeating the echo. Because I have 1 or 2 patients with CPVT who have actually developed non-compaction cardiomyopathy.
Okay.
So just as a precaution. And so we have to monitor them to make sure that that doesn't develop.
Yeah.
It's rare, but it does happen. And then so beta blockers are perfect.
Yeah.
Because you know the genetic mutation, if you need a second line agent, so what we use here is either natalol or propranolol.
We use propranolol.
Perfect.
Yeah,
That's perfect. You
yeah.
want that non-selective beta blocker, right?
Yeah.
Atenolol and metoprolol don't work as well.
Yeah.
I mean, they're okay, but propranolol or natalol work a lot better.
Yeah.
And you can go very high on that propranolol dose.
Yeah.
So for children at this age, we would typically do like a 4 milligram per kilogram per day dose.
Yeah.
And they tolerate it just fine. You want to push as high as you can because I in the absence of ICDs for these kids, right?
Yeah.
We medically treat.
Yeah.
So, and then a second line agent, if they have more VT on high dose propranolol, that will work really well is flecainide. I don't know if you have that available, but flecainide will work as a second line agent in these patients really well.
Yeah, flecainide I also have in my center, but in this case, we just start with very high dose.
Perfect. Yep.
Yeah.
That's perfect.
And,
Yep.
And the patient is still stable after that. The patient come back this year. I also see do the Hunter and ECG monitoring, and everything is look good. The patient is okay.
That's great.
Yeah. But as
when they're wearing the halter, have them run around.
Yeah. Just I
So
say
you
to
can
the
see
parent, everything look normal in your family.
Great.
Just go
Now-
around and everything. Yeah.
That's great.
That the heart rate is still under control, and no BBC. It look like normal. But one more question, that's so with this mutation, some patient will develop a non-compaction. So we follow up the patient with just echo or just with CMR in this case.
Echo is fine. And you don't have to do it that often because it's a rare occurrence.
Yeah.
Every few years.
Yeah. Every few years. Yeah.
Mm-hmm. And then we've had a couple of families develop it, but it's only 1 or 2 people in the family.
Yeah.
And it doesn't change much, right? Because the systolic function remains normal. And so really they're on beta blockers and flecainide, and I just worry about it.
Yeah.
So just as a precaution.
Yeah, just precaution. Okay.
But the important thing here too is, no, go ahead.
Yeah. Just I see that not only this mutation, as I remember, also other mutation of this CPVT, and I'm not sure about that. It's the most common. You see any other mutation of this CPVT? Because I just only see this type.
No, that's a good question. So if you have a patient like this with clear CPVT, right? They have the disease.
Yeah.
You will find mutations in RYR2 about 2 out of every 3 patients.
Okay.
There's still about a third who will not have mutations in this gene. The majority do, right? But some do not. Among that 1/3, a very, very small number will have mutations in other genes, the most common of which is CASQ2. Which is typically autosomal recessive. So they're homozygous and they get one from mom, one from dad. But that's very rare. And then there's other rare genes. And then there's a new syndrome that is not your patient. But there is a new syndrome called calcium release deficiency syndrome, where their children, they have cardiac arrest. But when you give them things like epi or isoproterenol, or they run, they don't get a lot of the arrhythmias. And it's a new disease, but they're also linked with mutations in RYR2, but the mutations cause different things in the heart. And that's only been described for the past 2 or 3 years.
Okay, it's just a new one, new description.
Calcium release deficiency syndrome.
So this gene is look like the first diagnosis I share in this slide, right?
So number 1 and number 2 are the same thing. They're the same
same
thing.
thing.
So number 2 is the disease, and number 1 is how. Oh, that's it. Sorry, calcium. Yeah, I would change it. So this patient does not have calcium release deficiency syndrome because the arrhythmias came out with the running and the exercise.
Okay.
The patients with CRDS, when they run, they have very little ectopy, but then they'll go into arrhythmias. So that's not your patient. So it's number 2. Yeah.
Okay. So the new syndrome may be the first diagnosis in here.
I don't think. So this is why they, they're just putting these things in here. Right. But your patient has number 2.
My patient is number 2. Okay. So very interesting.
Okay. So the other thing that's really important is to gene test just this mutation in both parents and in siblings. Because they may, if anybody who has this mutation can have the same phenotype, right? They can have a sudden cardiac arrest.
It's very interesting because I also discussed with some family member, parents, to do the gene testing, just focus to this gene. But most of them, they're afraid of when we check for the gene and maybe positive, they have to use prolonged beta blocker. But I try to explain to them it's very important because maybe the first symptom, maybe the cardiac arrest.
Is your patient, right?
It's very dangerous because this case is the first time the patient have syncope and cardiac arrest like this.
Exactly.
The first presentation of this patient. So I'm very worried, and I asked for the family member, but they that they come from province, they're very poor, and the cost of the gene testing is a little bit high compared to their income and not paid by insurance. So I try to convince them. And if I have more data about this case, I think this case is very interesting, very typical, and I can share with other doctor to use beta blocker in case like this.
Yes,
very important because some doctor they're afraid when the cardiac arrest, see a lot of VVC and refuse to use beta blocker.
I think that the use of early beta blocker for these patients is really an important point. And then this case is exactly the argument to make to do genetic testing. Right. So because there may be 10 other people in the family who are all at risk of death as the first symptom. So no, this case is really helpful to illustrate those important concepts.
So what about a cause of cardiac sudden death in children? CPVT is one. I see some one case or two cases long QT, but not sudden death, just a syncope, just a syncope.
Usually CPVT, the mutations cause severe disease earlier. Long QT mutations are more common. But they don't typically cause sudden death in children as frequently, right? So they're more common, but the sudden death proportion is maybe equivalent to CPVT. The other one, the other disease process that can be a little bit more common in Southeast Asia is Brugada syndrome.
Brugada syndrome,
Brugada syndrome. So that should always be considered if you have a cardiac arrest victim. Brugada syndrome. And that's important because Brugada patients do not do well with beta blockers. So if you have evidence of Brugada on the ECG, what we typically do is when they're in the hospital, if they're having lots of arrhythmias, you have to treat, right? And so we typically treat with beta blockers. If they've had an arrest and they're not having arrhythmias, we typically complete our evaluation first, and we'll do a Brugada ECG, with the high, we move the leads of the ECG to be over the right ventricular outflow tract. And if we see no evidence of that leading to on Brugada patterns on the ECG, typically we start beta blockers. and in this case, we would, depending on the child, we would try to run them on the treadmill to see if we can bring this out.
Yeah.
But for you didn't need to, because you have all the evidence in the of epi. So you essentially did it in the ICU, right?
Yeah. Okay. So thank you for this for your advice. All of my colleagues in here, if anyone have any question, you can ask Andrew. We have more 5 minutes to discuss. Hello, Dr. Hải.
Hi, this is Huang. Thank you very much, Andrew, for your time and expertise. And I think there's for the CPVT kid, do you I think I think that the sodium channel blockers may not be widely available in Vietnam. And is like, so would there be, and then if we have some, that it could be anything, depending on what's available, what could be brought in. In this case, then and then so would any beta blocker or any sodium channel blocker be better than nothing? I guess we can see it clinically, but in sort of a conceptual thinking. Yeah.
No, that's a great point to clarify. So Dr. An, Huang brings up a great point about not all classes or not all medications within a certain class are as efficacious in treating some of these diseases. Like we talked about, beta blockers are really important for CPVT. And the non-specific beta blockers like propranolol or nadolol are better. However, atenolol and metoprolol do have some benefit. It's just not as good. With second-line agents like sodium channel blockers, sodium channel blockers are not very helpful in CPVT, except for one medication, flecainide, which has a indirect effect that the other medications do not have. So flecainide blocks the ryanodine receptor. So RYR2 is the receptor in the heart that makes calcium-induced calcium release, and it leaks in CPVT. And so flecainide, and it's specific to flecainide, blocks that leak very, very well. So if the propranolol doesn't do its job and you're looking for another agent, flecainide is really the only second-line agent that we routinely use, not any other sodium channel blocker. Does that make sense?
Yeah.
And then I think for better for worse, I guess here would be better is that the limited accessibility to ICDs.
Yeah.
And so therefore we don't have to
have that conversation.
And that.
Yeah. I mean, I think, I think in this situation that conversation is easier to have, right? Because there's not as the same availability, but I think these types of children are the ones that, when medically treated, tend to do well. Tend to do well, and there was a wonderful study that was older children and young adults out of there's a large registry of these patients, Dr. An, across the globe, where we combine our cases so that we can see how these patients do. If you give older, talking teenagers, adolescents, and young adults, appropriate management with high dose beta blockers, the event rate for ICDs or fainting or sudden death events is very low. It's less than a 5% chance. It goes up if they stop taking their medications. It goes up if they don't get enough beta blocker. If you don't treat them with high enough beta blocker, the risk goes up. What I've seen also is sometimes if patients get sick and they're not eating or drinking and they stop taking their beta blocker, that risk is very high because then they're also dehydrated, right? But the good news is if you treat with high dose beta blockers, usually it's very well tolerated in children, and that sudden death risk drops tremendously. And so the question of ICD use becomes a bit more nuanced, a bit more challenging in a lot of these cases, in my opinion.
So that's yes, that's what I meant. Where it's so nuanced that I think when you don't have accessibility, in this case where it might not be as helpful,
it
would restrict our choice naturally, and so that in a good way, I think.
Right.
And then one last point is what are your views? Because I think in regarding sympathetic denervations, it kind of counterintuitively speaking, in resource-limited countries or resource settings, sympathetic denervation may be the easier, right?
I agree.
Easier way for given it's limited or acute like a procedure, right? And where do you think its place is in the armamentarium of management of CPVT in general, and here in our settings where medication counterintuitively may be more difficult,
right,
to get and manage than something more surgical.
Right, and so Dr. N, that's a great point that Huang brings up. These the left sympathetic denervation surgery, where you remove the sympathetic ganglion that innervate the heart, that create the adrenaline response, the catecholamine response on the heart. We're using that more and more as an adjunct. I think for your patient, beta blockers are the best thing. But if the beta blockers either are not sufficient, right? So there's arrhythmias that break through despite high dose beta blockers, and flecainide is either not effective or not available. Or in some situations where the patient is not on therapy, right? So they're far away, they don't have enough propranolol, so they stop taking it, and they don't have access to refills of the medications. All of those situations, I think, are times to think about whether a denervation like this would be something that could be done. Mainly because I sort of think of it as a permanent beta blocker. So it helps your beta blocker that you currently give be more effective, and it helps for the patients who maybe stop taking medications, are not compliant, don't have access to it, right? And it's a very straightforward procedure. It can be done in children of any age, all the way up to adults, and minimally invasive. So when we do it here, we do like even a 4 millimeter trocar incision in the left side. It takes an hour to do the procedure. They stay on their medications. They go home the next day. And it works really well. So especially for CPVT or patients with high arrhythmia burdens, it's something to consider. And we could that to me would seem like something that would be easy to come in, assist with, right? And then the follow-up is easy, right? Because there's no surgical incision, there's nothing different. You just treat them like you normally would. So if that's something to explore for these patients, and we have a great surgeon here that does them, it would be a wonderful thing.
Yeah. What about the sport activity? Because when we explain to family, after a sudden cardiac arrest like this, most of the family member is very afraid of when they say that is this type of rumors may be triggered by sport activity. And when we examination this patient, nearly they say that they don't want their kid join any sport, and they asked me to write a paper for school to ask to stop on other activity. But I say some activity is still okay because your kid is still in beta blocker, everything look good. So you have any advice with sport activity from your experience?
No. I it's funny because in the US, these patients will have a cardiac arrest and their parents want them to go back to playing sports no matter what. It's really amazing. So I think what you're doing right now by talking to the family about it and understanding what the family wants is really important. So I think if a family says we don't want the risk, we don't want them to play sports, I think it's very reasonable to say, I agree, because we know in CPVT that sports do bring it out. But with your point, Dr. Ann, I also agree that if you give a child a high dose beta blocker and they do nothing, they sit down for the rest of their life, they are going to get heart disease, right? They're going to get acquired heart disease very early. They're going to get obesity, diabetes, high blood pressure, coronary ischemic disease. So what I usually say is the reason that you want to take the beta blocker is so that your child can be a child, right? And if the parents are worried about sports participation, then what I usually say is, well, sports participation is different because you are being pushed. So when you're playing a sport and you're tired, you push through being tired. You keep going, right? The coach tells you to keep going, you keep going. And that's where I think a lot of the risk is for CPVT specifically. So what I say is, you want to control the arrhythmias enough that you can still do things that are healthy for the child, right? Play, run around. The child's 7, so, playing and running. If the child can't play and run normally, then we need to control the arrhythmias better, right? So we want that child to be active, but we don't want that child to, sit on the couch and do nothing, or sit down, do nothing, or have an on-field sudden death event that the parents are worried about,
Just one more question about the exercise testing. As we do the exercise testing before we recommend the patient with other specific sport.
Usually, yes.
Your center do the same.
At 7 years old, they're probably old enough to do it. But usually for us, we do a treadmill test as part of the routine evaluation. Because if the child runs on the treadmill and they have ventricular couplets, right? Couplets or VT, then we use that as a reason to go up on their medications or to change to adjust our approach. If we put them on a treadmill and they have isolated PVCs or bigeminy, then I think, or nothing, then I think we're well managed. So regardless of whether they do sports, we use the treadmill as a test of therapy, right? And in the younger age groups like this, if they can't run on a treadmill formally, then we just put the halter on them and tell them to play, right? Go run around and be a kid. And again, it's the couplets or more that is our usual trigger. You can also get into a situation where you treat everything and nothing goes away. But just knowing that that's kind of our threshold is what we do.
Thank you, Andrew. Fine. Do you have any question?
No, I think those Andrew made great points, and I think they're all applicable to what we have in Vietnam as far as what we can do, what we cannot do, and I think those kind of pointers are really excellent to be so that we can apply them in Vietnam, especially looking for more kind of permanent solutions.
So Dr. Ann, one of the things that that this raises the great point of is down the road, these kinds of things with surgeons coming to Ho Chi Minh City and doing these cases all in a row would be potentially something I think would benefit them. If enough of these cases are there, you think it would benefit you. This may be the situation where that denervation is most important, right? Yeah.
And for long QT too, maybe plus my.
It depends on the case, as you know.
Yeah.
But especially the parent where the parents don't want to treat with a beta blocker, maybe the beta blocker access is not universal, right?
Yeah. Okay. So maybe I will collect some more case, because as I remember some in the past I have some case like this, and maybe we contact with the family. We check again with the gene testing to be sure that it's CPVT or long QT or something. And I will write you for some short review like this. So if the case is enough, it's a good idea to do that procedure, because maybe if we do is maybe the first center to do the procedure in the south of Vietnam. Yes, it's very excellent idea to make decision to do the procedure for long term. It's look like long term treatment than beta blocker.
Well, great. Well, thank you.
Excellent. Thank you so much.
Thank you so much for your advice, Andrew. It's very helpful for us. My colleagues in here, we have some case from Dr. Chi and some case from Dr. Hải. And you have any question, Dr. Chi and Dr. Hải? Hello. Hello.
Hello, I'm Dr. Hải from Children's Hospital 1. So many thanks you and Dr. Hoang and sharing with us your knowledge. And many thanks Dr. An to share many cases, interesting cases. Honestly, we just know about genes result in the past few years. So our knowledge about the area is but not very well. So we hope in the future you can cooperate with us to analyze the result and to have a quick one. We have many problems of patients like cardiomyopathy and the patient with combined congenital heart disease and cardiomyopathy, and many cases autism like this. Hope to see you soon in the future in Vietnam. So many thanks.
My pleasure. I'm looking forward to seeing you in a couple of weeks. We should keep this going. So of course, when I'm there, we can talk about whatever you want. Do you think it'd be helpful for me to give you, just when I'm there, an overview of maybe sudden death indications and management strategies? I can just put together something for you, but then we can cover cases. And I'd love to make this meeting regular, right? Whether it's once a month or once every couple of months, something where we can meet, because I really enjoy it.
So I have a plan for you, just quick for you, that when you come to my center, I also introduce you to the university, Ho Chi Minh University.
That'd be wonderful.
So you can give presentation in there. And I have a plan to take you to Children's Hospital too. And Children's Hospital, new Children's Hospital of the city, to see the case in there. And I also prepare some patients. I have some patients for you to examination, and they also do the gene testing already. So you can direct examination, and like Dr. Hải discussed, in the future we want to develop this area, and if you need to do the research, we can collect the case for you, and you can send us the protocol or information. We will have you to fulfill the database, so you can you make the number of cases doing research. That
would be great. We can talk about all that. I'm looking forward to it.
Yeah, thank you once again. Thank you for your time. A little bit late.
My pleasure. That's okay. Well, thank you for your time as well. These cases were great.
And hope I will prepare some case, and we managed to have 1 or 2 months we have discussed some case like this. And once again, thank you so much, Andrew, and see you soon in my center. Yeah.
Take care.
We'll send over your agenda or your itinerary pretty soon.
Yeah.
In Vietnam.
You got it.
Yeah.
Thank you.
I will write the agenda for you, and I will mail you the agenda detail agenda for you. Yeah.
Sounds wonderful.
Yeah.
Awesome.
All right.
Bye,
Thank you.
everyone.
Thank you, Dr. Hoàng.
Thank you.
Thank you so much.
Thank
And see
you.
soon.
Bye.